I'm Spencer King. I'm visiting today with Jonathon Leipsi, who is from Vancouver, Canada, and very much involved in FFRCT. We're wondering if this is going to be the new wave for diagnosis and planning of interventional procedures. Welcome.
Thank you so much. Pleasure.
Now, you know, we've gone through a long period of sending people to the cath lab to diagnose coronary disease. I came along before clear procedures were there, before echo was there. We judged ischemia by an EKG and a stress exercise test, and mostly from the symptoms.
Sure.
And so it sounds like angina, bang, cath lab.
Right.
That was the way we were. And to some extent, it's still where we are with a lot of people. Although all our guidelines say, oh, you got to document ischemia and so forth. Now it seems to me that we're moving, fortunately, with the technology that's available toward diagnosing what's going on with people non-invasively with CT. Before we get into FFRCT, where do you think we are in diagnosis, or is SPECT scanning or remain an issue, something we do, or in Canada, for instance, are you moving more to CT-based evaluation of coronaries?
Yeah, that's, I think, a great way to frame it. As you mentioned, the whole concept of diagnosing or excluding coronary disease, especially with the reduction in the overall disease burden in the population we're serving compared to when you started practice, I think is probably not the right way. We need to inform the decisions around cath with appropriate, robust, sensitive, but accurate testing. In Canada now, we have a dedicated cardiac CT at my institution. We do about 25 to 30 coronary CT angiograms a day. It is the first-line test for coronary disease in patients with suspected but not yet confirmed coronary disease. So patients with known disease, patients with prior revascularization, they undergo stress testing with stress echo or stress nuclear testing. But for de novo symptoms, CT is the first-line test. It's more accurate, it's safe with a fairly low radiation dose, it informs prognosis, and it also informs medical management around the extent and severity of atherosclerosis. Do you or do you not have the atherosclerotic disease burden that, of course, is very much the driver of downstream myocardial infarction rather than treating risk? So it's changed our practice.
So you see the anatomy,
yes,
and then you're left wondering a little bit about, is this lesion obstructive? Are the symptoms the patient's having? Because, you know, as we get a little more mature, I'll use that word, a lot of us have something wrong with the coronaries, but we live with it the whole life, and that's fine. What is FFRCT and the other physiology-based measures? What is that adding to our understanding of what to do with the patient?
Sure. Well, I think that's spot on, and we struggle with this over many years, really, where we would find moderate coronary disease in the 40 to 90% range, not necessarily multi-vessel, single or multi-vessel. And the Achilles heel of CT was, no matter how accurate we may be with anatomy, which we're not perfect by any means, the spatial resolution is not the same as invasive angiography, but even if we we're still left with the Achilles heel of anatomy alone, similar to what we see with invasive angiography. So I think using advanced modeling from FFRCT, extracting physiology and pressure from a resting coronary CT, enables us to come over that final hurdle. You know, is this lesion that will or will this patient derive significant benefit from revascularization over and above medicine alone? Or will they in fact derive harm from revascularization in the absence of physiological significance?
Well, let's spend a moment thinking about, you telling me about what's going on to establish that. What kind of trials? How are we going to figure out if it's okay to go this way?
Sure. So right now there's one clinically used tool, and that's, as you mentioned, FFRCT, that was validated through a number of accuracy trials. The most recent was a study called Pacific, led by Paul Knappen from Amsterdam. And he showed and published in JACC in January of last year that FFRCT, while not perfectly correlating with invasive physiology, was better than other non-invasive tests. It had superior diagnostic performance. This is through the integration of computational fluid dynamics to a resting CT. Now, once we assume it's the most accurate tool, we also have to then understand whether or not it has clinical utility. And to address some of those issues of clinical utility, we've seen observational data from a registry led by Manesh Patel and myself and Kun Neiman, as well as Professor Akasaka, called the Advanced Registry, over 5,000 patients, and looked at how FFRCT informed the management of coronary disease. What we found was very similar to the invasive data. In this absence of physiological significance, an FFRCT above 0.8, the downstream event rate was incredibly low amongst those patients. Only 3 MI amongst 1,600 patients at 1 year. In the setting of abnormal physiology, what we saw as well was very much similar to the invasive data. The lower the value, the greater the hazard, likely the greater the benefit of revascularization. So no randomized data to date, although there is a randomized trial that was completed or is now done enrolling by Nick Curzon and will hopefully be presented later this year in the UK, and a randomized trial in the stable setting being led by Pam Douglas here.
Help us understand those trials just briefly.
Sure.
What's the structure of those?
So the forecast trial being led by Nick is a randomization of traditional care versus CT FFRCT strategy, and the primary endpoint is
now what are you starting with? You're starting with a symptomatic patient?
Symptomatic patient with stable symptoms.
Traditional care is what?
In the UK, it was at the discretion of the site. In the PRECISE trial, which is being led by Professor Douglas, the traditional care is a non-CT based strategy, a stress testing based strategy.
A lot of
nuclear stress echo,
yeah.
And in the precision arm will include CT FFRCT. Excitingly, in the PRECISE trial, again the trial led by Pam, what I'm equally excited about is the fact that there's going to be a sub-randomization which will lead to either no testing or testing amongst the lowest risk patients using the PROMIS risk score to inform that. So this will be the first randomized trial that will not only help us assess whether a CT FFRCT strategy is superior to a traditional care strategy, but whether or not amongst the lowest risk patients, whether no testing is safe compared to traditional testing. And I think this is really important, because the message to me as an imager, I'm always confronted with people who are saying, you just want to do more and more elegant or fancy tests. That's not the case. What I want to do is test the right patient with the right test at the right time. Some patients need no testing, but if they do need testing, I believe that understanding the extent and severity of atherosclerosis is the first question that needs to be answered.
Well, one question I always ask is, if you're going to order a test, make sure that you're going to do something with the result of that
Absolutely.
test. You're not just there.
Absolutely.
So, of the patients who are having FFRCT, how many of them, I don't want numbers, but how many of them go to the cath lab? Because one criticism has been, well, you do this and then everybody goes to the cath lab anyway, everybody gets all these measures anyway.
It's important.
Do you solve a lot of problems short of the cath lab?
Yeah, absolutely. I think we've seen that. Even in the setting of a stenosis, an anatomical stenosis, when the physiology was normal, with an FFRCT above 0.8 within the advanced registry, less than 6% of patients were revascularized at 1 year. The cath rates were significantly lower than in the setting of abnormal physiology, and significantly lower than what is traditionally seen in the setting of anatomical disease alone on CT, which often leads to, as mentioned, a cath approach because of the uncertainty of anatomy and the uncertainty of the hemodynamic significance of that anatomy. So I think that the role of FFRCT with the evidence would support the concept that it will help enhance the gatekeeping of the cath lab. It will improve the efficiency of the cath lab. We see a PCI to ICA ratio within the advanced registry of 75% compared to traditionally in the United States of 40% after nuclear stress testing. And in fact, when the site recommended that they go to the cath lab after CT FFRCT, the revasc rate was 85%. So again, not perfect, but really helping us understand those patients who not only have anatomical disease, but likely anatomical disease with abnormal physiology.
Well, having the anatomy and the physiology to make decisions, I think some people criticize, say, well, it's too much information, we might do things we wouldn't have done before. I think that you're on the right track. One of the limitations in the United States, I think, has been that we've not worked out the reimbursement correctly.
Totally,
Spec
especially CT.
scanning now is still reimbursed quite nicely. CT, coronary CT is not, and that's got to be solved so that we can understand how this can be applied in clinical practice. You're talking about 25 a day. I can tell you that I can't think of any place in the United States doing this kind of work. And it's not just Canada. I know all through
in the UK,
Japan, through Europe, this has become dominant. So I congratulate you on this work. I'm very excited about the possibility that we'll be able to do this. And I'm interested in the possibility this will all become an outpatient operation that may enable imaging centers to be done, that patients in rural, remote areas will not have to cast their lot with a cath. When someone in South Georgia and maybe in
rural British Columbia,
northern British Columbia somewhere, says we're going to send you off to the cath lab to Vancouver or to Atlanta. By the way, take your family because we don't know what's going to happen to you. They may operate, they may do. And the patient says, look, doc, just give me some more pills. If we knew all this information at some remote imaging center, read by the experts remotely, I think we'd make great progress. Anyway, thanks for visiting with us.
Thank you for the time. I really appreciate it. Thank you.